Hey, everybody, this is Whit Wilkerson, and I want to introduce our team. I'm in St. Petersburg, Florida. What about you all?
I'm from Dallas, Texas.
Laura Hooper here from Columbus, Ohio.
Same, Dublin, Ohio, same thing, Columbus, Dublin.
Tom Neighbors here, and I'm from Nashville, Tennessee.
And we're so happy for you all to join us. And this is our first meeting of the IDM Scholar Society Study Club. This is something that we hope to keep going for years and years and to build a large group of scholars, that's all of us, that want to share together and learn together and grow together and help our patients in our world. And so we wanted to just start by telling you, some of you haven't been with us before, haven't attended any of the events that we've held so far. So we'd like to just introduce you to the Integrative Dental Medicine Scholar Society, and then we'd like to hear from you. So let me share my screen. Also, I want to introduce, before we jump into that, Kim. Kim, introduce yourself.
Hi, everyone. I'm Kim. I'm the IDM assistant. I'm in Las Vegas, Nevada.
Great.
She's really the IDM genius, and she's going to run this show for us tonight. And when we get into interaction together, if you have a question or a comment, she's going to recognize you and unmute you so that you can speak as well. But let me start by just introducing all of us to what we're here for. So let's jump here into this, and we'll play this if it will let me. There we go. So again, I want to welcome you to our inaugural meeting. We're so excited. This has been something that we've been planning for, probably 2 years and talking about all through the pandemic and beyond. And so I know for some of you that are new, you want to know what's the purpose of the study club. And that's a good question for all of us to ask right now. Let me give you the statement about the IDM Scholar Society and why we even exist. This year, 2022, is the year that we've launched the IDM Scholar Society, and Patty and Laura and Gina and Tom and myself have all been very involved in AOSH, the American Academy for Oral Systemic Health, for a number of years. I think the organization now is about 12 to 13 years old. And being very involved in the leadership component of AOSH, one of the things that we had discussions about over and over and over again as a board through the last number of years is we get together for 2 days in September. We have unbelievable speakers talking about incredibly important subjects that have to do with the oral systemic connection. And we all walk away so fired up, but then we go home and we don't know what to do. And so our challenge has been implementation. And as a board member, I can tell you that we had many conversations about, could we do interim meetings? Could we do special events? Could we have some things that we could do through AOSH that would help our members become better able to implement what we're talking about? And we kicked that around and we talked about all the pros and cons and the challenges of, organization and location and all the details. And we just never were able to get anything started. So I finally decided that I'm getting too old to not do anything in the form of action in this subject of the oral systemic connection and what we're calling integrative dental medicine, the fact that it's so critical. And after just going through a pandemic, I think the whole world understands about comorbidities and how important it is to take personal responsibility for our health and for our patients to do the same. And so through conversations with Patty and Laura and Gina and Tom, we decided to start something ourselves and to do it with AOSH, with the blessing of AOSH, in collaboration with AOSH, But essentially what we are is a collaborative of health professionals, and that's not just dentists or dentists and hygienists, but it's dental teams and medical teams. Gina is a nurse practitioner with her doctorate in cardiovascular risk. You see Dr. Stephen Masley pictured here on this page, and Dr. Masley is an MD and one of the renowned integrative physicians in the world. He's been a keynote speaker at AOSH 2 times with tremendous response to his input on lifestyle and how important that is and the details of how to implement that. Stephen's agreed to work with us as one of our educators, and I'm excited for you to get to know him better and to learn from him. He's brilliant. And so this collaborative of health professionals means across the board. We want physicians and nurses and nurse practitioners and dentists and hygienists and team members to be involved. But here's our focus. Our focus is going to be on implementation. That is, how do we implement these great ideas, concepts, research that's being done, both from a clinical perspective, but also importantly from a business perspective. Because obviously, if we can't create a return on investment on these great ideas, then it's going to be very difficult to really enthusiastically engage in something and spend considerable amount of our practice time. But also our focus is going to be on empowering people. That is empowering us to, with confidence, address these issues, empowering our patients to take personal control of their health and responsibility, and also to empower our practices to be successful. So that's why we're doing this and what we want to do. What we want to ask right now is, and I'm going to stop sharing for right now, is that we would like to ask you what you would like to glean or learn or gain from being involved in this study club. So if you want to write in the chat, then Kim, you can unmute anyone that would like to make a comment or has a question, that they would like to raise. In fact, Holly Moons, I see you're with us. So maybe we could start with Holly. Holly is a phenomenal hygienist in St. Petersburg, and she works with the team right next door to us and a periodontal practice, also a surgical practice with maxillofacial surgery. But Holly, I know how excited and enthusiastic you are about this concept of integrative dental medicine. Tell us what you would like to glean or gain from being involved in the study club.
Oh man, that is a really tough question to ask, but because there's so many different things I want to learn, and I think that's the issue or the excitement with these meetings and presentations, is that you really go down the rabbit hole and you start to learn about this topic and that touches upon that topic, and you just get excited about one thing and excited about that. So I think maybe for me to hone it in on one thing would be, how can I connect better with those in the community from a dental perspective to the medical perspective? How do I build a bridge communication wise, letter wise, template wise, those first steps towards starting the conversation with others?
Yeah. Okay. That's great. And that's why we want this to be very interactive. We could, in fact, we've got about 45 slides ready for you tonight. And we kind of vetoed that and said, you know what? We don't need to have another webinar. We're all webinared out. And so so many of you have so much to share, and we want to hear from you, meaning what you're doing in your practice, how you're doing it in your practice, how it's working out, maybe new things that you're doing that we're not doing. So that's why we want to be together. Dwayne, I see you.
Hey, DeWitt?
Yes.
With that question, maybe Gina can help answer that, as being let's say, the only real medical provider tonight that we have, I think. That's all I can tell. Gina, what would you like to hear from a dental practice that would excite you in collaboration?
Well, one thing that I wanted to say in response to what you just brought up, which is such a great point, is I think it may be one of the key reasons that we are so excited about the IDM Scholar Society is because I know when I first went to the Baldonine preceptorship and realized that the dental and non-dental communities needed to work together, you make a few attempts to make that happen. And then you start to feel like you're just in isolation out there. Like, is anybody else doing this? And how do they make this happen? So I totally connect with what you're saying, that this community and the ability to continue to move forward, staying connected in this way is so important. But to just address quickly your comments about, how are other people or what's the best way to communicate? I think, and Laura, you chime in too, because she and I sort of do this as a partnership in my practice. And I think it's been really key to have a person on the team to help get started. And sometimes she starts with the administrative person, and sometimes she talks to the hygienist, and sometimes she talks to the dentist, and sometimes she sets up an appointment for me to talk to the dentist or for me to talk to the hygienist or whatever. I really like communicating directly, at least initially, if it's somebody I don't know and I have a patient in their city or that's already their patient. That's just my preference. I think we'll see a lot of different ways to make this happen. But I think initially, especially if it's a dentist or a dental hygienist or a team that you don't know, say, we've got a mutual patient, or I have a patient I would love to see you. I can send some records first, but I would really love to just explain this case to you, and I need your help, get your feedback. That would be my initial thoughts to that. Then you can really figure out with that person what their practice patterns are. When we have future patients, would you like me to, do you use old-fashioned fax, or would you just like me to send you a synopsis in text, or how that goes? And I would say, Laura, wouldn't you, that it's really different practice to practice how we then ultimately continue to communicate?
Yeah, I think there's two things. One, I guess how I want to clarify, just trying to get out there and get the word. I think a lot of people could add to this conversation. I see Cristobal, I see, Patty, I want you to answer, from speaking to your local diabetes, center, to even maybe your local hospital there are lots of ways to get people who are interested in what you're doing involved. That's like outreach, right? Going out. And Patty's on here. She can tell you, every year we did old school, took a folder filled with our information from our doctors and and brought a gift and cookies and things. Well, Patty didn't always want to bring cookies. She'd bring chips and salsa, sticking with healthy foods, or nuts. But I think just people being aware that you're there. That is, if you just think about it, people don't even know we're in the community doing this. So I think that's one thing, like what I call outreach. And then I dropped the collaboration form in there, and those can be templated with your logo on there. And it is kind of a nice form that shows what you've already done. You've already saliva tested, you've already done maybe a sleep test, or you've already done, a cone beam, and these are your concerns, because those things, when you do send them, they have to put in the patient chart. And to me, that's key. So Dr. Pritchard's telling you our way, and I want Patty to speak next. I do call. I make the initial call. I try to be as friendly as possible. I know there's a gatekeeper, but I do say I'm a dental hygienist, and I am from the team, and we are speaking of we want to talk about co-collaborate with your patient is now our patient, and right, who's the best person to speak to. And a lot of time it is the administrator, right? They're the gatekeeper. But I think once you can start sending them, whether it is just a saliva test, a period chart, you're getting somebody's attention, like, hey, and we would like to jump on a Zoom. There is something about getting on Zoom. Everyone tonight, we can all look at each other's faces. Hopefully you see each other's smiles. And Dr. Pritchard, don't you think that makes a difference? Whether it is the hygienist on the team or it's the actual care provider, like Dr. Pritchard, we have other medical providers who will get on. So I think
definitely my preference. Yeah.
Don't you think invite?
Yeah. And I think when you can get them to agree, which we haven't, maybe 1 out of 5 times, I would say, but it's great when the dentist or dental hygienist and the non-dental medical provider, the nurse practitioner, the MD, the DO, can actually get on with the patient, at least initially, because that just makes everybody's a fan from that point forward. The patients feel so taken care of. When have you ever been on a Zoom with two different teams, medical teams, with two different perspectives coming together for your care? And it doesn't have to take long. I love that, but Zoom is always better. Yeah.
Patty.
I would say persistence too. I think that, like Gina said, maybe 1 out of 5 will actually respond to you. That's a huge win. And we just have to continue to try to reach out to to the other discipline, whoever, if you're in dental, to the medical, or vice versa. And sometimes our patients have actually gotten us together, which is another avenue, just please invite your medical doctor or your dentist to talk with us. We'd love to get together and just, look at your case together as your team. Sometimes our patients have actually been able to orchestrate it better than we could, but there's certain disciplines. I know chiropractors seem to be so cutting edge and really, really interested in whole body health and, that. So we just have to continue to educate, and I just say, be really persistent. Don't give up, because some of them will join you eventually.
So I'm gonna say ours is kind of flipped. I would say, right, 90% of them get on the Zoom with us. We invite them to the Zoom, we ask them what it is, and they do jump in. So I think that's the other thing, is giving them, what I want to say, a definitive time and place, right? Because they can say, I'm not available, but I am available this day. And here's our Zoom link. And it's like, okay, you need to show up. So I want to tell you from the MD side, and Dr. Pritchard, please maybe speak to this, they're nervous. I think we forget that. We want to make excuses, they're busy or they don't have time for us. But I want to actually tell you, most MDs that I work with are actually a little nervous or scared or hesitant because they don't know what they don't know, and they're very aware of that. Mm-hmm. So I think being very inviting, and that we want to share the information we've collected. It's not putting them in a place that they have to feel like they have to be the expert. We're just providing this information for their chart, want to share, and want to get any collaboration or insight that they may have. And that's the word I use, any insight they may have on the case. So we're inviting them into the case.
Let me add to that also. I think all those great comments there. And Holly's question, really, I think we could spend the majority of my time on that because it's such an important question. One of the most important things that you can contribute in information is a salivary test. Why? Because it's a clinical laboratory model. Now, they might not understand, and they won't understand the test, but if you have a patient and you are referring to them and you're concerned whether or not they might be a diabetic or a heart patient, or they're going to have surgery or whatever, one of the most valuable things you can send to them, of course, are your clinical findings, but the laboratory test. And because they will want to know what that means, and you can explain that to them. And when I'm on that topic, I'd like to spend a couple of minutes, if it's okay, because there's a question about a laboratory test, I think, from Mary. Is Mary on? Mary Isaacs?
Yes, I think so.
Okay, great. And I'd like to address the topic on salivary diagnostics, because while we've had it around now for a number of years, it's still relatively new to the majority of dentists and hygienists and physicians and nurse practitioners in the world. But here, I want to address it from the standpoint of view of what salivary diagnostics actually is and what it's not. So let's start out, first of all, by saying what it's not. A salivary diagnostic test for the oral pathogens that we're looking at for today is not an antibiotic test. And the reason I say that is because I've heard people say, well, I tested for a while and it always came back the same antibiotics. Well, that's a misunderstanding of what a test is for. A clinical laboratory test is not designed to tell you how to treat your patient. You should know how to treat your patient, or you should know different ways of treating your patient. A clinical laboratory test is to provide, number one, a possible diagnosis. And that's what this test does. It provides a diagnosis for causation relative to periodontal disease, peri-implant disease, and systemic inflammation. And so let's make this very clear. So if you decide to use antibiotics, that's fine. If you decide not to, that's fine. That's not the clinical laboratory's job to tell you how to treat your patient. And so along that same line, I also would like to say what it is. So what is a salivary test? Well, it is a test from a body fluid that is designed to give information. The information that you are seeing now, like say the HR5 test, is relative to a diagnosis of causation around those two areas, periodontal disease and implant disease, gingivitis and so forth, and systemic inflammation. And then the test allows you then to make the clinical decisions as to how you're going to treat the patient. So it's a targeted test. Just like if you were going to Dr. Pritchard and she wanted to find out what your lipids look like, she'd do a blood test because she doesn't know that. So she'd do a blood test to see what your lipid panel looks like. If she finds that your LDL panel is high and she might recommend a statin drug, she's going to do that based on the test. Wouldn't you say that, Gina? You can't know that without that kind of information. So what is the target in, let's say, a metabolic panel? Well, the target might be glucose, it might be other things, but if you discover it, then it's your responsibility to decide how you're going to treat it, and there are multiple ways to do that. So what I suggest to you here is that for the really first time, we have a body fluid that is a true diagnostic test at the same level blood test is, or urine test, or any other body fluid. So what I also want to say relative to that is that it's important for us to understand it contains very valuable medical information. That information then is designed to guide what you do relative to the treatment. Now, as a laboratory, we can help you make those decisions if things don't look right after treatment or you need some guidance. We can help you there. But relative to Mary's conversation, and Mary, I would like to kind of address this to you. You said that relative to, you usually use a test when there's systemic or when there's local inflammation or bleeding. And I think that's an appropriate statement and maybe even an appropriate question, and that is, who should we test? And ideally, of course, we would like to test everybody. That's where we are really going with this. But some people will have, as you've indicated there, some of these pathogens and not have disease. So Mary, you kind of help me here. You say that here you have 3 of the 5 red complex bacteria. Do you have any kind of clinical inflammation or disease?
Yeah, can we unmute Mary and see if she can?
Mary?
I think in her sentence, it says that
Yeah.
she does not.
Yeah,
Okay.
I don't. I do have an implant that's not doing so hot, but I
Okay.
don't have any bleeding. I have good oral hygiene. I don't
Okay.
have any pocketing. So that was
Got
the odd thing.
Yes. Well, let's say this too, getting back to let's say the LDL panel. Gina may take a panel and she may find that you're high in LDL and she may recommend a statin, but your blood pressure may be fine and everything else may be fine, but she's going to use that test as a decision maker to help decide whether she's going to put you on medicine or not. Is that right, Gina?
Hey,
That's right.
Tom, I had a complete blood panel. There's nothing.
Yeah.
My cholesterol's fine.
Okay. I'm just using that as an analogy that,
But that's why I'm confused. It's like, wow, I would never have tested someone like me. But
yes,
here I
yes,
am.
yes. Well, what that should tell you, even so, maybe there's something going around that implant that you should be more concerned about. You mentioned that. And another thing about a salivary test is that it's looking at every area in the mouth. It's looking at every space between teeth. It's looking at implants. It's looking at your tongue. It's looking at your vestibule, and it's looking for the mucosa on the side of the cheek. So the fact that you have 3 of the 5, I would be somewhat concerned, particularly if they're at any significant level. So what's the level there?
You know what? I haven't looked at it for a couple of months. I just got treated. And
Okay.
So
Good.
I'm not sure. I don't think it was red. I think
Okay.
it might have been green and yellow.
Gotcha. Well, that's a great conversation. And what I've always said with the laboratory test is always look at your clinical presentation and the health of the patient as it relates to the test itself. I would also say, going back to the LDL concept, that if my LDL is high, I'm going to expect that Gina wants to get it low, even though everything looks good. And so in your case, even though you don't have any clinical information, there is a topic that we call subclinical inflammation. So what I would suggest is do everything that you can to get those reduced as low as possible. The last thing I would say is it possible that some people can have these high-risk pathogens at low levels and not have clinical disease. And yes, that is true. But it is a good warning sign relative to, let's say, the future health of your mouth or the future health of your systemic inflammation.
Okay, Dr. Neighbors, I can't stand it because this is one of my hot topics that I really am so passionate about because, and I want everyone to think about this, we are no different than the medical side than I'm going to say our Department of Hygiene is. And I want you to think about prevention, true prevention. We're talking about subclinical disease. We just got through a pandemic. And so I would love people to raise their hand. How many people know somebody who told you they were infected, they had COVID, and they didn't know it? They had subclinical disease. They didn't have what we call the iceberg concept of disease. They didn't see the tip of the iceberg. They had no fever, no coughing, right? This goes on all the time. This is a bacterial infection. The iceberg concept of disease is where you get infected and you don't know it. It takes time for this bacteria, what I call ensue, right? Patty over there, we call it fester. Who wants anything to fester in your body? Nobody, but the bacteria are making their way into the tissue. That is the inflammatory process, but you don't see the sign or symptom. That's going to take time based on each individual. So you don't see bone loss, you don't see bleeding. That's no different than the medical side. I love diabetes on this because people are insulin resistant for 10 years or more. They don't have a sign or symptom. They would never know. Same thing with a heart attack. Think about heart disease until something happens. So we're talking about subclinical disease. And I do want to pull in one of our other doctors here. Could we unmute Dr. Lauren Roper? Dr. Roper's practice, I want to actually, if she'll give me permission verbally, no names on the test, Dr. Roper, but I actually want to show you what it's like to screen patients who don't have necessarily signs or symptoms, what it looks like on a test, these early stages. I call this screening. When you truly screen your patients, you will see tests look very different. Dr. Roper, I can't see you on here. Could you verbally tell me if it's okay? I don't have any names, but I would like, hi.
Hi, it's okay.
Okay, perfect. And if you want to add to this conversation, but I do want to show, I'm going to share my screen here. And we're going to talk about, but I have tests that I love to use here that I say, find these patients that just have these low levels. Many of you never see patients like this. And I'm actually wanting Dr. Roper to let you know, these are in her practice. And this to me is screening. You find people who just have FN, who we're going to consider healthy. You will find people of these low levels here. Look at this, PG 10 to the first. Look at that, 10 to the second. This is an argument that I call about antibiotics. Many of us are waiting till it's too late, I say, till the patient then is having signs or symptoms. So I don't know how many of you have seen my cheat sheet. I would love for us to talk more about creating a cheat sheet for everyone's practice about this topic about antibiotics. When do we use an antibiotic? When don't we? And again, these are guidelines, and I just want to share mine. So I want you to be able to walk away. This somebody just says FN, unless Dr. Pritchard tells me, hey, we got a GI issue here, colon cancer and infertility. We're going after that FN. We're not going to be putting a patient on an antibiotic. We want to get it as low as possible. So we'll talk about other things. Do we need to do a GI protocol? Do we need just probiotics? Or do we want to just celebrate and tell the patient you're at goal? Then I look at FN and TD because they respond to treatment. They aren't in our resistant strain categories. So we want to be looking at, and then I always say, as a hygienist, we always want to give our patient a chance, right? It's like, I want to just clean them up. I want to just help them. Well, who are those people? I would say anyone who's below 10 to the second, why wouldn't I give them the chance? Because I'm catching it at the source. And Dr. Neighbors, I love, for you to maybe add to that, but there is something there about screening our patients and catching it early. Maybe it's a product I can get them on. Maybe it's a great treatment. These are the things we were trained to do in school. These are things we were trained in our CE courses to do. And these are the patients to respond versus the very hard categories. When I have this whole airway nitric oxide issue, when I have these super bugs where you have that V pattern or high TF and a high PG, right? It's like telling me you have strep throat, you don't want to go on an antibiotic, or you had a heart attack and you don't want to have a statin. I mean, I say it's too late. The event happened. And so looking at these categories, our hands get tied. So I wanted to bring that up. Dr. Roper, would you like to say anything about some of your low-level tests that you have seen?
Yeah, I'm so sorry. Phone died right as you were talking to me. Were you thinking mostly of Joanna with her remarkable test that we received?
I can show her before and after if you'd like me to. Can you talk about that? Yeah.
Yeah. So this is Joanna. We tested her she's one of our hygienists, sorry. So she has no clinical signs and symptoms, all 3 millimeter pockets and below, no bleeding, nothing, and came back with what we think is like a super strain, looked like a super strain of AA. And yeah, let's see if that one's her.
I might not have her before and after. I don't want to show her name. Okay.
Because that one looks like mine.
Okay, everybody HIPAA, right? Oh, here it is. This is her before. So see the top. She had AA, TF, and FN.
And so we do a lot of things in our office. We do ozone, we do probiotics, we do all these things without apparently without really knowing what it is that we're creating. So I think we gathered in Joanna's case that we were creating a superbug, or she was creating a superbug of AA in her mouth. And so this is after she did moxifloxacin. I hope I'm pronouncing that right. And so this is her resultant test after that treatment.
So I just think she was so excited. I wanted to show that. Two things. One, you found a super strain on one of your own clinicians, and she made the decision she wanted to go with the antibiotic, right? It was 10 to 6. We're in the millions. It's in the bloodstream. We were having that conversation. Where should we go? And she made the decision, if I'm going to take an antibiotic, I want to take one that targets what we call a super strain, right? That's going to be more effective. And so you can see then on her post test, really, I consider her almost clearing. I mean, she had low 10 to the second there. So what that's telling you is every other competitor starts at 10 to third. She wouldn't even register. She would look completely cleared on any competitor test. So I want people to be mindful of that as well, but just that her treatment worked. But you also have a unique practice in that you have lots of people that you are screening, that I want to go back to Dr. Isaacs, that have these low levels that you can see, you can give them a chance. Could we try a lot of those people who just had 10 to the first, 10 to the second? Dr. Roper has, I say it's almost harder because it's not 10 to the 6 million that, yes, they need an antibiotic, that, okay, we really have to think through this and use a product. Do you use lasers there, Dr. Roper?
We do not.
Okay, so I just wanted to address that. No, Dr. Isaacs, you're asking about lasers. The LBR is the uninitiated tip. If anyone would like to speak to initiated versus uninitiated, again, I think that's a philosophical, but we will say from some of the research we're seeing based on, again, those higher numbers. So I would say, again, if you have something 10 to the third and higher, I'm gonna say you probably need to go with your laser assisted therapy, your initiated tip. We just know you're gonna get a better result. And remember that's your pigmented species. So your PG, your TD, your TF, your AA, that's on that treatment guide. But you know, like those 10 to the first, 10 to the seconds, you do either one, the LBR or the laser assisted, initiated or uninitiated, you're gonna typically get a response right away. So again, to me, that's a different decision, antibiotics or not, from that.
I just think this whole conversation is so interesting because we have colleagues who've been testing for a long time. And sometimes it's like, well, who should we test? You know, the very advanced periodontal case is a no-brainer, right? But what? I should test myself. I'm a hygienist. I don't have pockets of bleeding. We've been fighting this for years where they're like, well, I haven't done my own test. Why would I test? I don't have pockets of bleeding. I mean, how disgraceful would that be to have bad bacteria in a hygienist's mouth, right? But what we found is that clinicians have bad bacteria. And, you know, we're a petri dish. I know Whit had a slide that he was going to talk about tonight where we have billions and billions and trillions of bacteria. We want to have better good than bad, but we all have some bad. And so, well, every now and then there's some lucky person that doesn't have bad, which I don't know where they came from. But anyway, it's been a real trip to find these clinicians who don't have the signs and symptoms, yet they have those bad pathogens that are driving inflammation in their body. So being of a preventive mind and building this preventive community, we want to think that way and know that, yeah, we got to pick up this disease early, and some of the biofilm is way ahead of us.
Can I share a quick illustration of what you're saying, Patty? I was speaking at a meeting now June, in Asheville, North Carolina. Dr. Mark Piper, who's probably the most noted TMJ surgeon in the world. And Mark is off the charts brilliant. He finished #1 in his class at Harvard College, #1 in his class at Harvard Medical School, Harvard Dental School. I mean, it just goes on where, you're very insecure being around him. But anyway, I was speaking to his TMD study club in June, and I went through about salivary testing and oral pathogens and the inflammatory cascade that can be created from the mouth throughout the body, throughout the vascular system. And when I finished my presentation, Mark stood up in front of the group and he said, it's all about diagnosis. What we do is about diagnosis and presenting to the patient, what we see based on our diagnosis, based on our testing. And he said, from what you're saying and the implications of what you're saying, if I was a practicing dentist today, I would do a salivary test on every patient once a year.
Yeah.
Now, we haven't done that in our office, but the point is, what are the implications of what we're talking about going forward as far as if we're oral physicians, and our primary responsibility, probably above all else, would be no infections or inflammation coming from the oral cavity to the rest of the body, which we know is a huge connection, then that would be our #1 priority, is to absolutely make sure people don't have infections. If they do, we treat it. And then we monitor everyone to make sure that, just like blood pressure, cholesterol, et cetera, that we are closely monitoring that. So that's true. We're going to keep direct diagnostics very busy.
Let me add to that. You used the term, what are the implications? A couple of things I'm working on relative to how else can we use saliva. So first of all, I want to say to those who are starting saliva, this is just the beginning. I have been in contact with a group out of Australia who's already involved in a clinical trial of just using saliva for looking at both A1C and also for blood glucose. So that clinical trial will need to find out more information about that. So theoretically speaking, you will be able to look at A1C, be able to look at blood glucose, whichever one you want or both, relative to what Whit just said. What are the implications? The other thing that I'm looking at is gingival clavicular blood. So we have another source of looking at A1C or blood glucose. We have clinical trials that go back to 2012 that say gingival clavicular flood is as accurate as venous blood, is accurate as a finger stick. And so I am looking at the possibility that we can use venous blood or saliva for diabetic testing. The ADA is recommending that. ADA always has to have 2 insurance codes for that. In 2021, ADA came out with a very powerful statement saying, yes, dentists and dental hygienists should be involved in diabetic testing. And the American Diabetic Association also agrees with that. So I'm just telling you that to say what you're doing now is very important, but it's going to be even more important as we start using saliva for actually diagnosing people who have prediabetes and diabetes. I know some people are already doing that in some of the states with finger sticks. But we want to be able to do that either through gingival clavicular blood or through saliva itself. That is the most non-invasive way that we can do that. Again, reading the literature on that, and my wife is a perfect example. It's almost impossible to find her vein. She hates to go to get blood drawn because you have to use both arms and they have to tie them down because it takes a lot of work to find her vein. And those that finger stick, and Gina, I think will appreciate that. And those of you who may have diabetes, you get tired of doing that. If you have to finger stick a lot of times, and you do if you're type 1 or type 2 diabetic, that's uncomfortable. So bottom line is you are going to be able to provide patients hopefully in the near future, information relative to their diabetic status, either whether they are non-diabetic or diabetic. So hang in there because we're going to bring some more tests out.
Where will insulin resistance fall in that category?
Well, yeah, I don't know yet, Patty. That's a great question, but hopefully it'll fall in there.
Do you mind if I have us talk a little bit about antibiotics since we mentioned them? Let me show you a slide or two here just to stimulate conversation, because this is something I've been thinking a lot about lately, and we've been having a number of discussions about this. Let me see if I can find up here. Okay, so let's say we do our testing, and there are recommendations for potential help here. Laura, you mentioned the V shape, Laura, on our HR5, and here's an example. Some people on the call, on this discussion, don't know what you mean by that. Would you explain it?
Sure. We have research and lots of literature that has come out with documentation of what's called an oxy-R protein. And Dr. Pritchard can give you all the fancy chemistry and everything behind what's called like super oxides. I'm going to give you my hygiene version. They're like super strains. These are where specific bacteria, PG and TF, actually co-aggregate. So they work together with FN, and FN actually changes the environment. So this microbiome, they can change that environment from being what we call, we're normally an oxide or a chloride. So think about a lot of your over-the-counter products, think about your chloride products, think about your hydrogen peroxide products that you're putting on somebody. They're able to then sustain in the oral cavity. So they mutate enough to stay alive, and sometimes they thrive because then that oxygenation or these other products are actually killing what I call these lower level species. So they're actually knocking out the good common souls, and what they're leaving behind many times are what I call the super bugs or the super strains. And we have lots of documentation on that. What I want you to know are who are the 2 of the 5 that you're looking for that really take advantage. Remember, they're opportunistic. That is TF and PG. And so on this test, we can really see that with PG. I call them the towers. You see FN and PG real high, and then that dip down in the middle, the V there. And so understanding that a biofilm bacteria, they grow very stepwise and very specific, it would look like a downward slope, which this, okay, it starts a downward, but then it comes back up. That is not normal growth of a biofilm. So I think just visually recognizing that, and thank you, Whit, for pointing that out if somebody isn't aware of that. And if you need that research, please, that's on our site to be aware that that to me is another huge reason you want to test. Huge reason.
Can you add to that, Laura, the impact that PG has on FN?
Well, I think that you are the expert, but
well, what I would like to say there is some of the questions that we have are, well, everything is 0 but FN. Should I be worried about FN? And the thing that we need to recognize, gets a little complex here, is there are genetic variations of every one of these microorganisms. And we actually test for all of the genetic variations, but we don't put them all in separate lines because we are, for the most part, still trying, as let's say a profession, figure out these 5. But what we need to recognize is that FN is a commensal, and generally speaking by itself tends to be favorable toward health. There are exceptions to that, particularly in the presence of PG. Microorganisms converse with each other through a mechanism that is called crosstalk. And one of these areas of communication is through gene transfer. In other words, PG, and there are a number of genetic variations of PG, some more toxic than others. But so since we're just showing one line here, we assume we are having the toxic ones and the non-toxic ones in this one line. So PG, the virulent ones that are there, the toxic ones that are there, can actually share its pathogenicity with FN. So even if FN is a health-associated microorganism, it becomes virulent because of the presence of PG. Okay. So anytime you have the presence of PG and FN together, well, you always want to make sure you knock out PG, but particularly when they're both together. Target PG.
So we get this test result back and we read through the possible recommended therapies, which can include antibiotic therapy. Yeah. We all know that the typical antibiotic therapy historically for oral pathogens is going to be amoxicillin. And in fact, it's so interesting, isn't it? Now that we're learning about this, we recognize and have for what 30 plus years that pathogens in the mouth can be dangerous for vascular risk. And so we're not talking about an elephant gun for a mouse when we're talking about antibiotics, but we're really going after these bugs and sometimes super bugs. And in fact, we've now identified 5 that are the high risk red complex keystone pathogens. But here's what's very interesting, I think, about antibiotics is that traditionally today, the majority of what would be used to treat any of these, with most people not having an idea which ones are even there, would be amoxicillin. So Laura or Tom, please comment on amoxicillin's effectiveness against PG, TF, TD, and FN.
Oh, I don't know.
Or is it not? That's my question.
Okay, is that better? Good. Well, we know that PG is truly a gram-negative microorganism, and we need to use an antibiotic that targets gram-negative anaerobes. Amoxicillin targets primarily facultative. So amoxicillin wouldn't be your drug of choice. metronidazole initially we have used, but we now have the moxifloxacin as well. Actually, Laura sees a lot more cases than I do today. Would you like to add to that, Laura?
Well, it's your basic science. And so I want to simplify it in that, and I know, Dr. Wilkerson, you have those slides. So I kind of want to get to that, right? Speak to that, that the amoxicillin really is targeting those facultative species. So in our lineup, that's going to be AA. Right. And the chances of somebody having AA, Dr. Neighbors, what is that statistic? It's pretty rare.
Say that again. What's the question?
The chances of having AA, it's not very common.
Yeah, AA, I think we should all fear AA. When we look at the history of the discovery of AA, it came from the African continent, but is now, of course, in every continent. But it is not as widely dispersed in populations as PG is. So when we look at the literature, depending on which one you look at and look at large numbers of patients, we find AA only in somewhere between 12 and let's say 15% of the population. When I did some analysis of about 40,000 case studies, we showed AA anywhere between 10 and 20%. So not a lot of people are going to have AA, but when you see it, really be concerned because it's extremely pathogenic. I think it's as pathogenic as PG. It's just that we don't see it as much literature written about it because it's not found as often. But be very wary of AA for sure.
Okay. And comment on moxifloxacin.
Okay, Laura, go ahead. That's one of our newest ones there.
Yeah, I think that really it's looking into the research that this has been an antibiotic used on the medical side with lots of success. It is in the fluoroquinones, but we need to have great communication with our patients. And Whit, I'm going to have you speak on that because if you can't actually get moxifloxacin, the study was on these resistant strains. So the big study was on AA, PG, and TF, your three most resistant strains or aggressive strains that will create what I call some of these super bugs. So like that, if Dr. Roper told you her hygienist had AA, we were very concerned. So it's like, okay, if we're going to use an antibiotic, we're actually going to make that choice. We know metronidazole is only 70% effective. So that hygienist had to make a decision on her treatment. Do I want to go in with a 30% failure rate? Or do I want to go in with a higher susceptibility rate where moxifloxacin, however you want to pronounce it, help us, has 100% susceptibility rate in a lot of the research. So that's why then we go to that second choice many times when we have the resistant strain. But Whit, unlike Dr. Roper, who could get our hands on it, what has happened in your area?
Well, in our area in Florida, as I have prescribed moxifloxacin, I've had pharmacists say they don't carry it. Mm-hmm. And so we've had to drop back to either metronidazole or metronidazole and amoxicillin, depending on what we saw there on the study, on the report. But very interesting. One of the nice things I like about the moxifloxacin is it covers all the bases and you only take it once a day for 10 days. So that's really nice. But one of the things that's so interesting about what we're learning, isn't it, is that if you were to ask, for example, what would you give a patient who's had a hip replacement or a knee replacement or had some kind of heart procedure before they have their teeth cleaned prophylactically? I mean, 100% of the time you would hear 2 grams of amoxicillin 1 hour before. And yet now we're looking at this and we're saying, wait a second. We're identifying 5 keystone pathogens, of which AA would be probably the least likely to be a problem. And we're giving patients sometimes 2, 3, 4 times a year 2 grams of amoxicillin, sometimes for the rest of their life to have their teeth clean. And we've never tested them. we don't know if that would be helpful for anything at all, but certainly isn't going to be helpful for everything. And so I began looking a little bit at some of the most recent literature on dental work and prophylaxis and antibiotics. And it was so interesting to see what I found. Here's one from 2021 talking about prosthetic joint infections of the total hip and knee. And it says, for high-risk patients, the American Academy of Orthopedic Surgeons recommends amoxicillin prophylaxis. However, no systemic review of the literature of prosthetic joint infections associated with dental procedures explores if amoxicillin is suitable for the reported organisms. What's missing here? What's missing is testing. Then the results show that an estimated 46% of organisms may be resistant to amoxicillin in this one study. What's missing in analyzing the individual patient? It's testing. And the conclusion is lower extremity prosthetic joint infections associated with dental procedures is often caused by organisms unlikely to be prevented with amoxicillin. Well, how do you find out? Through testing and looking at more information about antibiotics here from the ADA. It says there are currently relatively few patient subpopulations for whom antibiotic prophylaxis may be indicated prior to certain dental procedures. Some patients with cardiac conditions and compromised immunity, they say. And then they go on to talk about prophylactic antibiotics since 2015 are not recommended prior to dental procedures to prevent prosthetic joint infection. So most of the time what we're doing, isn't it, is we're calling the orthopedic surgeon and saying, what is your protocol for your patient? They don't have any idea. Some will say 6 months, some will say a year, some will say 2 years after surgery, some will say for a lifetime. And they're all just guessing because there's really no testing going on. And that's exactly what we're talking about. And here we see, as we in dentistry are just prescribing antibiotics like candy, it says general and specialty dentists are the third highest outpatient prescribers for antibiotics, suggesting 35 to 80% of these antibiotic prescriptions are either not indicated or suboptimal. So we want to fix that. That's what this group is all about, is that there's science and then there's these typical, usual and customary approaches to things that really aren't scientific. And these are the things that we want to dig in together and become the leaders in these subjects. And so I just wanted to show you all that.
Let me make a couple of comments there too. How much time? I'm not looking at my clock here. Where are we?
We're good. We're good.
Okay. The antibiotic question is always one that I've been very concerned about. And that's the reason I introduced the idea that this is not an antibiotic test. And so please, I want to repeat that. But there's a two-way sword here with antibiotics, and there's a couple of chats here on people having problems, and that is true. There's a risk, obviously, in taking systemic antibiotics. There's a risk for the patient in not taking antibiotics too. As an example, there are at least 4 legal trials for periodontists and dentists that treated periodontal disease. Of course, that would involve dental hygienists as well, without antibiotics in the presence of purulent exudate or pus. And every one of those cases, the patients developed brain abscesses. When they tested the abscess fluid, it turned out to be either AA or FN or TD, and they tested the mouth, and it turned out to be the exact same genetic variation that they found in the mouth. So what I'm just saying here is, again, as a laboratory, we're not saying you have to use antibiotics. You have to use good sense, and you have to protect the patient as best you can. There's risk both ways. So just make sure you have a good medical history, particularly on antibiotics. Make sure, though, that when a patient does have purulent exudate, that you do really have to be very, very careful about protecting their brain and heart.
Mm-hmm. And you see some comments in the chat about moxifloxacin and some possible side effects. Laura, you want to comment on that?
Well, I just want to make sure you don't allow the pharmacist to downgrade it to the Levaquin, because that is in the fluoroquinone family that does have the side effects that we don't want our patients to have. So the C. diff, the tendon ruptures. And so another maybe conversation at some point too is about the C. diff conversation. You know, on the medical side, what do we give patients who get C. diff? Metronidazole, guys. So metronidazole is one of your safer antibiotics. And people are saying all this antibiotic overuse, Dr. Wilkerson is showing you the science behind those, what I just want to say, broad statements. They're talking about amoxicillin. They're talking about the amoxicillin that's been overused. They're not talking about your metronidazoles. They're not talking about the meloxifloxacin. So, you know, we're looking at very specific targets here. And Dr. Pritchard, please tell us about Mark Cuban's website that we use. Please share. It's groundbreaking.
Moxifloxacin ophthalmic is on there. So, I mean, it's not going to help us out, but you can request them to add prescriptions. And so I'll just request it and I'll keep everybody posted. I don't know if they'll add it or not. Maybe y'all should go on there and request it too, because the more people that request a medication be added, they're more likely they're going to put it on there. They're adding new ones all the time.
Can you
I put
tell
the
them
link to his
it?
site on there. What?
Tell them about his site. A lot of people don't know. I don't believe anyone, I don't know too many people in the dental community who are aware of it.
Oh, Mark Cuban started a pharmacy or a pharmaceutical outlet with an online presence. It's mail order. And the prices are incredibly low because he's apparently making no money, but charging just enough overhead to keep the lights on or to cover employees and that kind of thing, and is making no income from it. It's like his kind of charitable way to give back, and the prices are incredible. So I put the link in the chat, and hopefully we can get moxifloxacin and others on there.
Right, that's good.
Mike Milligan, what are you up to, brother? Can you unmute Mike? Hey, Mike. We can't hear you. I think you're unmuted.
Well, he's getting unmuted. We can't hear you. No, there you are.
Yeah, we can hear you. Mike Milligan, for those that don't know him, is a former president and leader of AOSH, and just a great pioneer in this field of oral systemic medicine. So thanks for joining us, Mike, from Illinois. Tell us why you'd like to participate in our study club.
Can you hear me?
Yeah, a little bit.
Because you guys are doing a phenomenal job, and you all are at the very top of you were talking about did we test the test?
We can't hear you very well, Mike. It's kind of broken up and not very loud.
I am sorry. Just love you guys, and you're doing a great job, and thank you for all you do.
Okay. We want to hear more from you when the audio is working better. What about Susan Estep? I see Susan on here. Susan is the immediate past president of AOSH and has an amazing practice in Atlanta, Georgia, and another founder of AOSH going back to 2010 or 11. Susan, what's up?
Well, hey, everybody. And hey, Mike, my dear friend, and all of my dear friends. Well, I'm in first week back of high school, and I still have the privilege of braiding Sammy's hair before bed. So while I study club, I'm still trying to do all this other stuff. But Laura and Whit, I'm just and Dr. Pritchard and Patty, I'm just super excited that you guys have put this thing together. I am very excited to be here tonight, and you're my people, so I'm sitting here and literally you think that you're applying everything that you can possibly apply in your practice, and then you come into study club and you're like, I'm not doing anything, but it's very motivating to be doing this. I personally, my biggest question about tonight's topic really does lead to the antibiotics, because, you know, in everything that we learn through AOSH and all of the other avenues where we learn, there's a fear of prescribing antibiotics. There's a fear of dysbiosis. There's a fear of this. And so over my years, I have grown more and more, I don't want to say afraid, but I've just become less and less prone to prescribe antibiotics. And so this is one of the places where I really want to learn and hone my practice.
Well, I'd like to make a comment on that if I can, Susan. I think we all are afraid of that, particularly as a laboratory. We don't want to encourage the use, but we want to make it available. But having said that, I think that it is important that we look at medical histories very closely. We look at the numbers of times people have taken antibiotics and all of that. But the other thing is treatment. And one thing that we've tried to do at our laboratory is find different ways of treating these high-risk pathogens without antibiotics. And so I know we're trying to keep data on that. And as we all know, oftentimes we get kind of caught in treating periodontal disease one way, whether it be ozone or lasers or just getting and root planing. But again, like medicine per se, and I keep going back to, let's say, lipids, if one statin drug worked for everybody, we'd only have one statin drug. But we have at least 5 different statin drugs, don't we, Gina, that are available to us.
Yes.
That treat patients that don't respond to the first. So I think in our practices, we have to have multiple ways, multiple avenues of treating infections that are these infections that are resistant to what we are doing. Not totally wiping out or say I'm never going to use antibiotics again, because that's the other two-edged sword. We don't want people to end up with very, very severe infections as a result of what we're doing. But I agree. I think that we need to just have different ways of treating these infections. And if we need to hold off and say, okay, I've done everything I can do and it's still there, then that's another way to approach it. So each one of you are going to have to make that decision on your own. We can't make that for you, but we know it's a very serious topic.
Yes, Susan, I'm so glad you brought that up, because I would say 2 things. One is we are desperately looking for herbal remedies. I know Laura's working with some other hygienists on trying things like oregano and other herbal combinations to see if there's anything else we can use besides antibiotics, because it does wreck the gut. And so whenever I'm teaching on this, I tell anyone and everyone, particularly in the medical community, non-dental, we're the worst. Anytime you give an antibiotic, at the very same time, give the protocol to rebuild the gut, because you're wrecking it. And so just to give the antibiotic without rebuilding the gut is doing a disservice. I mean, you're helping one thing. When you solve one problem, you have 10 others, right? So you solve the oral micro bacteria problem, but you've caused problems in the gut. So you have to heal it. We talked about that a little bit on the previous meeting, but we'll have to make that a subject one night, because everybody wants to know what's the best way to do that. There's a variety of ways. So we should talk about that on one of these meetings.
Good.
Well, and I'm very passionate about this, because most of us want to say we're oral systemic, and Dr. Pritchard knows where I'm going to go. We don't cut our heads off at night and set it to the side. Mm-hmm. So to me, that's why I'm going to scream at everybody, like, screen your patients before you need the antibiotic. But again, we wait till it's too late. And then you're trying to argue that you have a million species in the bloodstream. I want to know how we're getting rid of them. Because again, the blood circulates into our parotid glands, right? Dr. Neighbors, we make our saliva. We have this circulatory pattern. Your patients are swallowing those bacteria 700 to 1,000 times a day. I argue every day. I don't even argue. I want to make the statement. If you have leaky gums, if you have these high-risk pathogens, you have leaky gut.
That's true.
So I actually argue we're helping the patient by giving them an antibiotic and pulling that down. And then Dr. Pritchard has amazing GI protocols to help heal and seal those same epithelium linings. What's your famous line? You said it today to one of our patients from
tongue to tail.
Mhm, mhm.
Yeah.
Well, maybe we should discuss that on a different meeting, and where Gina, you just go through your protocol for restoring the gut or protecting the gut, and exactly what you do.
I think that's also another great reason for this group, because that will be a forever ongoing topic. Because once you learn a few things that work, then you learn things, better ways to do it, because our understanding of really this whole concept is in its infancy, but we do know some things. We have some things that work pretty well, and it'll just get better as we go along. So yeah, we should make that a topic in the future.
We definitely should do that. Unmute yourself. You're muted.
Can you all see the slide I just put up?
Yep.
Okay, so this is 2022 April, pretty recent. And this is from a cellular biology research team in South Korea. And listen, and they're not dentists. The oral cavity is the gateway for microorganisms into your body, where they disseminate not only to the directly connected respiratory and digestive tracts, but also to the many remote organs. Oral microbiota traveling to the end of the intestine and circulating in our bodies through our blood vessels not only affect a gut microbiome profile, but also lead to many systemic diseases. By gathering information accumulated from the era of focal infection theory to the age of revolution in microbiome research, we propose a pivotal role of leaky gum as an analogy of leaky gut to underscore the importance of the oral cavity in systemic health.
Great slide.
Yeah. So are we on the cutting edge or what? I want to ask Amber Auger, who is a thought leader in among dental hygienists, to weigh in. Amber, can we unmute Amber and say hi?
I'm looking for her real quick, just can't find her. Give me just a second.
She's there. Amber lives in Boston.
There we go.
And
sorry, y'all.
Thank you.
Amber.
Hi, how is everyone?
We're doing great. Thanks for joining us. Hey, I have a question for you. As you go around the country and interact with dental hygiene geniuses all over the country, where are we with salivary testing? Are most familiar or not, or interested in implementation? Where are we with all that?
So where we are with all of it is that the hygienists are extremely interested in it. Most have heard of it, but most don't understand the difference between the HR5 tests and other quality and the quality of tests that are out there. The other issue always comes down to time and money. So I'm on a mission to change that, to change the thought around how we need to start implementing the test. And I have been implementing the HR5 test in our practice since April, and it has literally changed my life. I get to watch my patient not only get healthier, but we're also reducing the anxiety around systemic health issues and putting the power back into the patient's overall perspective. So it's been really rewarding on a whole nother level than I ever anticipated.
Great comment.
And can I ask Dwayne? Thanks, Amber. You're the best. Can I ask Dwayne Jones, who lives out in Washington State, so all the way across the country from us? Dwayne, what are you hearing out there about salivary testing out there in Coyce country and Spear country and very strong academic community around Washington and Seattle? Can we unmute Dwayne?
Can you hear me?
Yeah, sure can.
Well, I think it's coming around like across the country. My colleagues, some are familiar. I don't have a colleague as a general dentist that is routinely doing saliva testing. So I sort of feel like I'm out there a little bit of tip of the spear.
Yeah.
Out there. But then I realized how much I need this group, and it's like I feel like I'm back in college again. It's just like, and that's one of the things that you started with is how to make this a business plan. And I think we're all here getting the knowledge and everything, but then how do you turn that into a business plan that you can incorporate into a holistic oral systemic type of practice?
Love it.
One of the things that I'm finding in my practice is a lot of the things that I'm doing and want to do, they're not accepted by dental insurance companies. And in my practice, we are steering closer and closer to being completely dental insurance independent, because I just don't see that they're doing anything for us. So with that, it also brings in that I have to learn and use medical insurance, because that's what everybody here is talking about, medical testing. So I think that maybe this group needs to look at that as an opportunity for practitioners like myself and that are drawn to this group. This is like, well, how do we make this pay? It's like, well, you can't count on your if you're tied into dental insurances, they're not gonna help. So, I know that using medical insurance is becoming more and more popular. It hasn't becoming more and more easier. It's still really difficult to do. And my administrative staff, when I try to bring in some, trying to coordinate this and say, let's go learn how to do this. It's a chore, and like lots of things, a lot of overworked people don't want to take on more chores and duties. So that's one thing that
Michael Martin had something on that too. Michael, can you hear? Michael sent out a note there in our chat. Michael, can you hear? All right, we need to unmute Michael.
Yeah, I know things are good here on the West Coast. We're testing a lot. I'd really come back to echo what Mark Piper said, is that we really need to say what our diagnosis is before we give anyone an antibiotic.
Right.
And I just want to be really clear that currently that means having a periodontal chart, and we need to show each other what that looks like.
Right.
We need to have some radiographs for people. And we also need to start using really clear language, in that a salivary test isn't descriptive enough for me to know quickly what someone's talking about, because the world's exploding with inflammatory marker salivary tests and viral salivary tests and fungal salivary tests, and we've got a lot of them. And so we just need to be really clear what we're talking about. And that when we're talking about adding antibiotics into treatment, that's usually antibiotics in conjunction with scale and root plane, because we really do need to get in there and get deposits off teeth to see people switch towards health. Something came out about FN. There's a paper by Diaz, which talks about the shift of bacteria families from health to disease. And they talk about FN being kind of a core species that we see both in health and in disease.
Right.
So there's lots of good stuff out there. I'm excited to get down to AOSH. I know some of you guys will be down there. You guys are brilliant if you can get through all the course selections. That is hard. So kudos to you guys that got through that. That's all I have.
Thanks, Mike. We're all gonna be at AOSH. And by the way, if you aren't involved with AOSH, we certainly want to promote it. It's September 15th through 17th in Phoenix, Scottsdale area. And we're all going to be there. And I think most of us are going to be participating in the program, but we're very excited always to get together. It's such a phenomenal community, and that's our roots. That's really where we're coming from. So we will definitely see you there, Mike. Okay.
Chris Duvall, can you hear us, Chris? You had your hand up a few minutes ago.
Well, it just leads me back to A couple of things. I started a wellness program in 2001. And so since then, I've been using lasers, both with an initiated tip and uninitiated tip, as part of my protocol for how I treat. Then I added ozone in 2008. And I think it's critical that we get to that point where we get as many arrows in our quiver as we can to treat perio and these bacterial infections. And I think also that my whole goal is to try and help shift mainstream dentistry and hygiene and even medicine, and to have them understand we're there to not clean patients' teeth as our main goal. Our main goal is to help our patient create a healthy biofilm.
Right.
Because without that, we're sunk. And without that, our patients are living routinely in what I call the danger zone. And that's where, when we don't pay attention to clinical evidence, it opens up, for whatever reason, we're ignoring it or not doing saliva testing, and that it just opens up our patients to a huge amount of disease and even death. So I am so passionate about this, and I'm so glad you guys are on this road. So, you know, my goal is, I think we should help everybody with bacterial testing, particularly, and with use of lasers and ozone and whatever else you've got in your quiver. We need to get our patients in the safety zone. And my other big point is that right now we have such a mismatch between our clinical protocols and the science we know today. And we have got to do some major work to get hygienists and dentists and physicians and nurses to understand that how we're treating our patients today just isn't good enough anymore. And I'm so glad you guys are on this path. I'm right there with you. There's an army of us, but we need the collaboration and the work and the help of parents and teachers and you name it. I don't know if any of you had a chance to read it, but I wrote an article that was published in the AOSH newsletter last month. It's called Who You're Going to Be. And I think until we decide who we're going to be for our patients,
there you go,
that's going to drive what we do. And so I'd encourage you to read that article, because we're all on the same page and wanting to do the same work. So
yeah,
good for you guys.
Chris, can you answer that question for Dr. Isaacs? Mary asks, and you are the guru on here. I know Amber, you could put too, if you want to put in the chat. All my laser people are on here. I would love to just people see. She asked about the lasers. Should she be initiating, not initiating? I'd love to just get some quick responses. Love to hear your input on there.
Well, here's how I used it for a protocol for hygiene, for recare, is I used an uninitiated tip. I went around the sulcus, every single tooth, and decontaminated. And then when I did periodontal therapy, I used the tip initiated, and I removed the granulation tissue, because my goal was to give the tissue a jump start. Why not remove that granulation tissue and then let the immune system go to work? And so I combined lasers with ozone, and it's just a really fun way to practice. So yeah, I'd encourage you to use lasers.
So what are you seeing on your result reports with this combination therapy, befores and afters? Are you seeing a real positive, significant elimination, reduction? What are you seeing?
Absolutely, a good reduction.
Good.
But I also want to point out one thing that my sister showed me. She had 4 of the high-risk pathogens and 2 of them above threshold. She removed removed every single one of the high-risk pathogens with self-care. And I think we forget about that aspect, because if somebody really shifts the amount of time and effort and how they're cleaning their mouth, you know, brushing their vestibule and their cheeks and doing tongue scraping and all those other things, I think we forget about the impact of that. Of patients that really want to make an impact can have a huge impact on how their outcome.
I agree. You bring up an amazing point. And those of us who remember Paul Kais and Tom Rams and so forth, that was a big part. And the one thing that you mentioned too, we definitely know that in this group that our goals are much higher than what we were taught in school. And we have good meta-analysis that prove that, even as recently as March of this year. We're leaving roughly 1/3 to 2/3 of our people still infected after therapy. And then we're asking them to brush and floss. So what I oftentimes say is, I know we call periodontal therapy non-surgical. It's really a surgical procedure. It's just not as bad as using a scalpel. But we create a lot of bleeding. The point that you're making there, and the point I make, is that we have started the healing process. But when you finish 4 quads and you say you're through, we aren't. Now we've got to begin the healing process. And that's what you're saying.
Yes, and that's, I make a big point when I finish therapy on a patient. I say, I've done all I can here today to begin the healing process. Now I'm turning the healing process over to you. You must continue it, because what I do today alone will not solve the problem.
Yeah, if it were a cut, we would put maybe some kind of antiseptic on it, or a Band-Aid or something. But since it's the mouth, we can't do that. So there are other things that we have to do to, as you're saying, keep the bad ones from regrowing so that the good ones repopulate. The good news is the good ones repopulate much faster than the bad ones, and there's many more of them. And so when they repopulate, they help prevent the bad ones from populating.
Yeah.
Hey, y'all, thank you so much for this conversation. We want to honor our time. We've got 4 minutes till we wrap it up for tonight, and we're just getting started. But I want to kind of give you a preview of where we want to go in the future together. And so tonight was primarily about oral pathogens and testing and antibiotics and therapy options. We also are going to be talking, whoops, if I can advance here. We're also going to be talking more with Dr. Gina about arterial testing, CIMTs, carotid intima media thickness testing and screening. And in our classes that we've had so far, we've had probably almost half the people in the class have CIMTs while we were together during our courses, and it's been fascinating and very relevant. And then sleep studies, we'll be talking about that and how we use those, but it's all about, isn't it, diagnosis? And that's what we want to really elevate in dentistry and medicine, is diagnosis-based treatment to coming up with true, solutions that are going to save lives. And it's all about this inflammatory cascade, which is presenting itself in so many different aspects and forms throughout the body. We've had conversations, and Laura, I know you could comment on this more, but with time, I'm afraid we can't. But just simply looking at airway and pathogens and plaques in the arteries, lack of oxygen, increasing pathogens, and creating more pH, just all these connections now that we're starting to appreciate and explore. I also want you to know that we're going to have some fantastic people involved with us going forward. And I'm having lunch tomorrow with Dr. Stephen Masley. These are his books that he's written. He's just a genius. And so I'm going to ask him if he won't join us perhaps at our next study club meeting and talk to us about integrative medicine and lifestyle. So I know you want to be on that, because it's going to be very personal. I think all of this really starts with me, meaning me embracing these changes, and then being able to share that with our community. We're also going to be engaging. I've been speaking with, as some of us have, with Nathan Bryan, who is really the leader in research on nitric oxide, and Leonard Pastrana, who's a PhD pharmacist in peptide therapy and supplementation. I mean, just some fantastic things that we're learning, and people that we're connecting with that we haven't introduced you to yet, but we're going to. And so the courses that we're going to be having is really set up like this. The next course I'm announcing tonight, because we just decided this week that we're going to have an inflammation and infection workshop October 21st and 2nd. But because we don't really have time to set it up, we're going to do it virtually as opposed to in person. And so you can go on our website and learn more about that, but we would love to have you join us for that virtual. It'll be from 9 to 3:30 on Friday, and then 9 to 1 on Saturday. And we're going to go through really much of what we've talked about tonight, but much more in a clinical application implementation way. We have an airway and breathing workshop December 2nd and 3rd, and then we'll have a foundation seminar in January, a revolution, which is a symposium similar to AOSH, but 6 months apart in April, and then a TMD and occlusion course in June. So here's what we want to offer to you as our study club members, that for everything that we're doing in the way of courses, you're invited, of course, and we will give you 10% off as a study club member if you put in SC10. That means Study Club 10 code in any one of the courses that we do. We're going to be at AOSH, and we'll have a table there at AOSH and interacting with all of our friends and colleagues there. And so we look forward to being there with you as we promote this movement. And we're trying to really find our success by knowing our purpose, which I think we found, and trying to reach our maximum potential. And through that, sowing seeds that benefit other people, as John Maxwell so aptly said. So help us if you would. Invite your friends to join the study club. There's no cost to it, as you know, and we just want as many people as possible to be involved. Our next study club meeting will be Wednesday, October 5th, same time, same station. So we look forward to seeing you there, hopefully sooner than that at AOSH. And thank you for your commitment, and thank you for encouraging us by being with us tonight as we seek to really create a true revolution in dentistry and medicine. So we'll talk to you soon. Thank you, everybody. Thank you, Laura and Gina and Patty and Tom for being with us and leading the way tonight.